A very good morning to all of you. Very recently, we completed a comparative cross-sectional study among Indian classical music major students in comparison to their age-matched non-music students. Our idea was to explore if any long-term active music engagement has any kind of association with depression, anxiety, stress, sleep quality, and quality of life. And what we observed was that a larger number of music major students belonged to the normal side of the DASS scale, Pittsburgh Sleep Quality Index, and the World Health Organization Quality of Life Index. Now, to reflect that onto this particular image from 2017, published in Translational Psychiatry, we found three important aspects, which explains the psychoneuroendocrinology of music. Relaxing music, any music that relaxes somebody, that is going to lower the cortisol levels, which is the stress hormone, by influencing the hypothalamic, pituitary, and adrenal axis, and also reduces the cardiovascular responses by modulating the autonomic nervous system. But again, on the flip side, any music that triggers somebody in terms of memory or volume or intensity or anything that triggers a patient is going to have the opposite effect. And thirdly, music is going to have an impact in the cerebral blood flow by increasing the blood flow, and that kind of particularly has relevance in neurological music therapy, which is in gait and motor and stroke rehabilitation specifically. Now, music's impact on pain is something that we are continuing to explore, and one of the recent discussions from 2025 by Dr. Stephen and Dr. Yokabrat et al., one of the leading scientists trying to understand the mechanistic aspect of music's psychoneuroendocrinology. So what they found in figure C is that active music, so particularly sensory motor synchronization to music, meaning music with a particular rhythm and basically that engages patient to do some motor activity, for instance tapping or snapping with the particular musical rhythm, that's going to have a greater effect. So basically the active music, the figure C, the first graph that you can see, what it shows is that music is going to reduce pain, and that also had a very good effect size of around 0.93. So basically this happens because music engages with the with the overlapping pleasure and pain circuits. So basically, due to the extensive similarities in the anatomical substrates underlying painful and pleasant sensation, pain and pleasure processing mutually inhibit each other. And as I said, it's still something we are trying to understand, and this is one of the latest hypotheses. Now, looking at this map, the pink and the purple are the countries from where a lot of music psychology, including mechanistic and randomized control trials in music, particularly like in hospice or palliative care or any other oncologic setting, has come from. And very recently, I was in University of Dar es Salaam in Tanzania, Africa, and we were trying to initiate conversations on how these countries like India or other countries in South Asia or East Asia or Africa with such diverse musical cultural repertoire, we are still not able to tap that and produce positive evidence using rigorous, meticulous, randomized controlled trials. And recently in 2025, we published the very first systematic review meta-analysis of randomized controlled trials that tested, tried to understand the impact of classical Indian music for managing anxiety and pain among patients in a hospital setting. Now, this is a vast umbrella which included all kind of clinical, diverse clinical spectra, but yet, unfortunately, you can see all those red bullets and the red bars. That shows that the existing current evidence with local Indian music has high risk of bias, and starting from, starting from sample size estimation to perhaps any, details about the interventions. It was, there were so many gaps. And also with grade analysis, what we found was that the certainty of the existing evidence was very low, meaning you cannot trust those evidences that well. Now, as we all know, randomized controlled trials are the gold standard research designed to test a particular intervention because it has lower risk of bias. But before designing a protocol, I think what's very important is to have a core team. PI and co-PI are self-explanatory, but your relationship with your medical statistician in research is very, very important because most of the, or all the research that we saw in our meta-analysis lacked rational for that sample size calculation. Randomly, there were like 20 patients and 20 controls. That we all know that's not how it's done. So that kind of, you need to find a medical statistician who is familiar with designing RCTs and has published RCTs. Now, sample size calculation, and then if you do not find a reference study, particularly that happens in music-based interventions, most will be pilot feasibility studies. So you can have a pilot study and you can have an interim analysis and then amend based on and take it from there. Trial estimates, very important. None of the studies in the existing music-based intervention RCTs had that. A solid statistical analysis plan, recruitment forecast, like every week, how many patients are you recruiting and what is the number of patients are you stopping and doing the interim analysis, a plan for outcome analysis. Now, the fourth most important person here to collaborate with will be a musician. So I have said in the previous IAPCONs as well that India does not have NMC accredited music therapy training program, and as a result, no board certified music therapists in the country. So I think the best we can resort to is somebody, a musician, perhaps somebody who have completed their master's program in music. And then research assistants, again, very, very important because in the last slide, all the red bullets that we saw was because of the lack of blinding or masking. There was no information whatsoever about the allocation concealment. So it's very, very important to have at least like 2 research assistants when you're conducting a study. RCT. So in 2025 June, there was an amendment of randomized controlled trial protocol guidelines, reporting guidelines, and there were 34 items that has to be there in the proposal, in the protocol, but I'm just highlighting a few things. I would say eligibility criteria, very, very important. Clarity of that in population and also in comparison, very, very important. Time point of main interest, day 0, day 7, day 45. I know this might sound like, if you're used to randomized controlled trials, you might ask like, why are you talking about the obvious things? But then it's very important because all the studies that we observed with music-based intervention in palliative care or in oncology settings, it did not have these important points. Trial setting, even within hospice setting, like you need to have that clarity of, and specifications are very important. Interventions we'll discuss in the next slide. Primary and secondary outcomes. So basically there are so many tools and questionnaires. So I would say for anxiety, and particularly if you're measuring music, you would measure like pre-intervention and post-intervention. So it's very important that you choose the right questionnaire or right tool. For instance, for anxiety, I would say there are plenty of questionnaires, but for moment-to-moment, like pre and post, I think STAI would be a good tool to begin with. If you are measuring stress objectively, then I think salivary cortisol and salivary amylase would be, again, this would require some amount of funding. But then there are plenty of grants within, I would say like in the UK and Europe that are ready to give you grants in music-based intervention research. It's only a matter of asking and seeking. Again, sample size and randomization are very, very important, that you have to sit with your medical statistician and then discuss based on, customize that for your particular study. Allocation concealment, one of the most popular methods that we use is sequentially numbered opaque sealed envelopes. It's basically something to mask the participants from knowing the group allocation before. Masking, again, one question that would ask is in music therapy or yoga or aromatherapy or acupuncture, isn't it very obvious? Patient will, I mean, it's impossible to mask the patient from that intervention. Yes, that's true. But then still there are guidelines that would say you can still, within that boundary as well, you can reduce the risk of bias. Perhaps, for instance, I would say crossover RCT, or perhaps providing another arm as a sound intervention. I would say in classical Indian music, I would say Rag Yaman and Rag Puja Thanashri or something like that. So maybe a patient who's not familiar with interpreting or distincting or finding a distinction can be masked that way. Implementation and data collection, again, it's very important to have multiple people in your team, maybe research assistants who are masked to these study objectives. Then statistical analysis plan has to be there. And then once your protocol is ready, then ethics approval and CTRI registration. 2025 was a great year. It had so many amended guidelines coming up. And music-based intervention has its own reporting guidelines. By Robb et al. In 2025 had amended their own guidelines from 2011. So, which includes these points. One, I would say quickly go through. Strategies. So passive listening is only one of the music-based interventions. There are many more. Again, these are actually done by trained music therapists who are absent in India right now. But that said, we can still begin from somewhere. Maybe instead of, you can seek the help of a musician, and instead of like passive music listening, you can have an intervention that's like based on improvising a particular musical piece, or encourage the patient to do a bit of songwriting. And RAS is rhythmic auditory stimulation. That's basically, there are plenty of videos on YouTube where you can visually see a Parkinson patient before music and after music with the rhythmic entrainment, how their gait improves. And then intervention credentials, very important. But in an Indian setting, again, since we do not have a board-certified NMC accredited music therapist in the country, perhaps a master's music student might help with that. And then the unit of your intervention, is it individual or like per group? Intervention rational, again, very, very important. You cannot randomly choose a specific music and give it to the patient. So for instance, if in Carnatic or Hindustani music, I would say Rag Yaman. Why do you give Rag Yaman? So if you ask me, I would say because it's a Lydian mode, and it's a major scale, and it's the happiest musical mode, one of the happiest musical modes. So that would be my rationale. So you can choose a devotional music and say, because the patient grew up listening to that music and that brings joy to them. So that could be a very valid intervention rationale. Music selection, again, who selected that music? Is it the patient? Is it the researcher? Is it the musician? Compositional features, very important, particularly for neurological and gait training, whether tempo, rhythm, pitch had any kind of impact. Again, I'm so sorry I didn't have enough time to go through all of this, but then, sorry, it would sound like drinking from a fire hose, but you have a detailed 1 hour, 2 hour RCT designs on my YouTube channel if you would like to watch. Thank you so much. Any questions?
Hello, excuse me. Do any of this pre-recorded music, videos or music, does it help?
Yes, yes. There are plenty of randomized controlled trials that have shown positive impact in various clinical spectrum, including palliative care and hospice, that shows recorded music has, and basically there are comparison between live and recorded, and some even would say, some studies would say even recorded music had a better impact in comparison to live music. But unfortunately, none of these studies are from India. So that's a challenge. But there is positive evidence. But we have to develop that positive evidence in India and in local Indian music.
Just one question. How do we ethically randomize in, in a setting like palliative care where, it is difficult with the prognosis of the patient? How do you ethically randomize in that subsetting?
I didn't understand the question. Like when you, as in like, is the question because the control group is not receiving music, and that's
Yes,
kind of
yes.
So we are doing a randomized control trial back in like Kasturba Medical College, Mangalore. So what we are trying to do is that control group who does not receive music at the end of 7 days, which is our time point of interest, we give the music that the case group listened to them. So that's how.
Thank you.
So, if I may add, firstly, thank you so much for introducing the expressive therapies for the session. I am myself an expressive arts therapy practitioner and I know about music therapy. So, just to add, and if at all it helps you, there are a few music therapists in India as well. One of is practicing in Bangalore under Maya's Universe. So, I think if it helps you, she did it from Lesley University or somewhere, but she's practicing here. So for your further help, if you need, you can connect with her.
Yeah, I think I know her. I think she did from Berkeley.
Berkeley, yes.
Yeah. But so that's a great thing because that's an AMTA accredited ones. But I hope India also gets more
Yeah.
NMC accredited training programs.
Yeah.
Thank you. Thank you.
Thank you, Dr. Tara, for introducing us to such an interesting concept and the rigors of RCT design. Now I'd like to welcome Dr. Natasha. Dr. Natasha Verma is CIPLA Palliative Care and is associate